Okay. Hi guys. Hope your weekend went well and everyone's staying safe. For sure, I have been checking out those Netflix options for you guys, and yes, I am hooked. So thank you for those suggestions. They have actually helped me pass some time. So I waited as long as I could for any emails, any questions that you might have had, but I didn't receive any. So I decided to post this today, being our class period. You guys obviously can use this and reference it and go back as often as you need to. The exam 2 review is going to be kind of limited based on specific points since there were no questions asked, but I encourage you all to attend SI with Bree this coming week. Again, our exam, it's next Wednesday, okay? So let's dive straight into the elbow and the forearm. So a few topics to touch on. We're going to go over bones and landmarks. We're going to talk about the kinematics of the elbow and the forearm, specific muscles that you'll need to know, and then just a general overview of the entire PowerPoint lecture. And then we'll talk about exam 2. So let's go over the bones. Nothing new here. We have the humerus, like we talked about last week for the shoulder. The two new bones that we're going to mention now are the radius and the ulna. Shouldn't have said nothing new. There are two new bones. Sorry, guys. The radius and the ulna. We have specifically 4 joints in this area. So we have, this is the radius, obviously. It's labeled. We have the humeral radial joint, where the humerus articulates with the radius. We have the humeral ulnar joint, where the humerus articulates with the ulna. And then we have 2 radial ulnar joints. We have the proximal radial ulnar joint, and then we have the distal radial ulnar joint. Now these 2 articulations here, we have the radial head that sits perfectly against the ulna here. And then we have down here, we have, again, the styloid process of the radius, and then again the radius articulating with the ulna articulating with the radius, and the styloid process of the radius here. And then you can see the carpal bones that are going to form when we talk about, not next week, the week after, we'll talk about the wrist and the hand. So here's our humerus. We talked a lot about superior landmarks for the humerus. We're going to talk about distal landmarks right now. So let's look at the posterior view. We have the olecranon fossa, where that olecranon is going to hook into perfectly to allow us to perform that 1 degree of freedom that this hinge joint will allow us to do, which is flexion and extension. We have the trochlea, which can be viewed posteriorly and also anteriorly, but you notice the shape does change in the front, allowing that olecranon to go into that coronoid fossa, which is right here, okay? And then we also have a radial fossa, where this is the capitulum right here. This is a convex surface which will sit perfectly within the radial head on that fovea. I'll show you that in the next slide, to allow flexion and extension to occur at this articulation. We have also the medial epicondyle and lateral epicondyles, just like we would for the femur. Not that much different, okay guys? So here's what I mentioned before. This is called the fovea. This is that articular cartilage that allows the capitulum and the radial head to articulate with each other and allow flexion and extension at the humeral radial joint. And then we also have, see how the radial head sits perfectly against the ulna, which over here we call the olecranon process. And it forms like a hook, which is, again, the design of the distal humerus will allow us to perform that flexion and extension movement. And you'll notice as we travel distally, you can see in between the 2 bones we have this membrane. This is called the interosseous membrane. This allows for force distribution to be equally distributed throughout the radius and the ulna for closed chain activities, weight-bearing activities. And then again, down here, the styloid process. If I'm having you guys label like bony landmarks, I need you guys to be very specific if it's the radial styloid process or the ulna, or the styloid process of the ulna. Just be very specific of which bone you're referring to, because I will take off points if you do not, okay? Let's take a look here. Okay, so you can kind of see that hook that I was talking about before. We have our olecranon process that sits within the olecranon fossa. We have that anterior notch that I mentioned before, where this sits perfectly into the coronoid process of the ulna, and then we have the radial notch, where the radial head will sit and articulate with the ulna, thus creating the proximal radial ulnar joint. Another view here. See how this sits perfectly inside. Now pay attention to here. See how the radial head sits into the ulna? Well, it has to be held together by a ligament. So that, because remember before when we talked about the scapulothoracic, it's not a joint because there are no ligamentous connections. Well, here's our ligamentous connection for the proximal radial ulnar joint. It's the annular ligament. Annular ligament. I need you guys to remember that, okay? So again, this being a specific classification of synovial joint, we of course have articular cartilage. We have ligaments that kind of keep us in place, allowing us to not have too much excessive valgus force or varus force within this joint. The medial collateral ligament, also referred to as the ulnar collateral ligament or the UCL, it has 3 sections. So you have what's called the anterior part, the oblique part, and the posterior part that provide that stability. Oftentimes, baseball pitchers especially will have overuse or even tearing of this ligament. The surgery, I'm pretty sure you guys have heard this before, it's called Tommy John, thus the Tommy John being the individual who had the surgery to repair this ligament that tore on him. And we have also here on the lateral aspect, we have our radial collateral ligament, and here's our annular ligament again that keeps our radial head within the radial groove. Now, I really want to make this clear. See this picture? This is the brachial plexus. We talked about this in class. If I had, say, these blank, you would be able to tell me that this superior one is a C5 nerve root. Again, roots, the trunks, divisions, the cords, and the nerves. I do not care about the labeling of these specific sections. I just want to know that you know the sections. Does that make sense? So if I had a blank picture, I want you to know that this is C5, C6, C7, C8, T1. Oh, I know that these are the nerve roots, and I know this is where the trunks come in. I know these are the divisions where they start to split up, and then they become the specific cords, which will form the nerves that my professor wants me to know, which would be the musculocutaneous nerve, the radial nerve, the median nerve, and the ulnar nerve. Axillary nerve is also important, so please know that one. But like as far as medial, posterior, lateral, don't care. Anterior, posterior, don't care. Superior, middle, inferior, pretty easy, but again, I don't care. This is what I care about, this is what I care about, this is what I care about, and all these little peripheral nerves that you guys need to know. This is not the best picture, but it's going to show you where that ulnar nerve is going to sit in that what's called a cubital tunnel. This is on the medial portion of the elbow. That ulnar nerve is going to come down and sit perfectly within a groove. You can actually palpate this on yourself if you actually rubbed your medial elbow and you felt like a little like canyon almost or a little crevice. Your ulnar nerve sits right in there, and especially if you hit that thing, it's referred to as hitting your funny bone. That's because you've just sensitized this ulnar nerve and you've pissed it off. And it's going to be painful, but you're probably going to giggle about it because you don't really know how to interpret that pain. And not to say that you personally don't, but your body is like freaking out. Again, the UCL will sit perfectly, the 3 portions, to cover this ulnar nerve, but oftentimes this guy gets really annoyed because there's not a lot of space to move. It can get stuck, and then oftentimes the muscles over it will push on it and cause pain and discomfort. Again, enter a baseball player or even a thrower who has medial epicondylitis or medial elbow pain or associated with ulnar nerve entrapment or a torn UCL. What they'll do is they will actually move this nerve. They'll transpond it and move it to another location, either over here, so that it's no longer pinched. Again, normal carrying angles. We mentioned this with the knee. We talked about valgus and varus being knock-kneed or bow-legged. This carries over into the forearm, specifically at the elbow. So if you stand in anatomical position just like this individual is, with your palm facing forward, you'll notice that your elbow creates an angle from your side and allows your hand to either rest closer to your leg or further away. This is normal cubital valgus where you have a carrying angle, relatively small. You're not really cubitus varus where you're coming into yourself and your hands are over your thighs. But a lot of times you'll see individuals who have a wider carrying angle where they're sitting very far apart from themselves and they've got this huge gap between their leg and their hand. This is also a really cool picture. Again, if you're squeamish, I'm sorry, I should have warned you. This is an x-ray of a dislocated elbow, and it's fascinating because I don't really see, I'm not a radiologist, but I don't see any fractures present here, which is nice to see because this can easily be reduced. Most often the olecranon on the neck or the bone here will actually break off and you'll have more problems. But what can happen in the design of this joint specifically, especially if you fall in an outstretched hand, you can actually push your ulna back and it will dislocate posteriorly, but it can be reduced fairly easily. It's very painful to do, but it's very interesting to see that this can come out so easily. And again, if you have kids, you have siblings, you babysat, or you work with kids, you probably are mindful about how you carry them. Especially this little guy right here, he looks like he's having some fun. Hopefully that's a parent lifting him off the ground. But you see what I talked about before, the annular ligament sitting perfectly to hold the radius into that radial groove against the ulna, which, you know, again forms the proximal radial ulnar joint. If you pull too hard, you can actually pull the radial head or the radius completely through the annular ligament or rupture it completely, dislocating the radius from the ulna. And causing a lot of problems. And little kids, like, I mean, obviously if they're not, you know, listening to you or following you and you need to drag them along, try not to drag them by one hand or one arm. And if they're walking the dog or something and the dog takes off and they're holding it by one hand with a leash, this can occur as well. There's YouTube videos of little kids having their elbows reduced. There's one little girl, the doctor's trying to make it as painless as possible, but it's cute, but it's super sad because she's obviously not happy because it hurts, but that's pulled elbow syndrome. Now, the kinematics of the elbow and the forearm, it's very unique compared to the leg because obviously our fibula is not going to rotate on a fixed tibia, but our radius does rotate on a fixed ulna, which is really cool. So we again have two specific joints. We have the proximal radial ulnar joint and we have the distal radial ulnar joint. Now, at the proximal radial ulnar joint, we have a concave surface, being the ulna, and we have a convex surface, which is the radius. Now, remember, convex on concave, remembering that specific movement is occurring here, but distally, the opposite is true. We have a concave surface, being the radius, moving on a convex surface, being the ulna. Isn't that cool? So being mindful of that, what's occurring at which proximal or distal joint, that's a nice little monkey wrench in our system to remember. Again, another picture for anatomical position as this guy is in here, right here, and then going into pronation, that radius is going to move on a fixed ulna. All right, guys, so let's get into some muscles, okay? We have our primary elbow flexors. We have three. We have our specific, well, not specific. This guy right here, oh, no, not yet. The brachialis is actually our strongest elbow flexor that we have. It's deep compared to the biceps brachii, which is superficial to the brachialis. But looking here, we have two heads of the biceps brachii, remember that. We have the long head that goes through the radial groove into the superior labrum, and then we have the short head, which attaches to the coracoid process. Okay? And then we have the brachioradialis, which attaches to the distal humerus and then attaches onto the radius. And then our brachialis attaches to the humerus, to the ulna. Let's see. I'm going to show you guys a quick video so you can easily differentiate between these three. Hi guys. All right, let's walk through the elbow flexors, okay? So we have three that are the primary elbow flexors. We have our biceps brachii, we have our brachialis, and we have our brachioradialis. To differentiate between these three, the biceps brachii also aids in supination of the forearm. So in order to test it, I'm going to be in supination. Okay? Supination and elbow flexion will test my biceps brachii. If I want to test the brachialis, I'm going to be in pronation and elbow flexion, and that will test my brachialis muscle. Now the brachioradialis, because of its attachments from the humerus to the radius, it's at its most optimal position when it's between pronation and supination, just like this. And then I'm going to be able to do elbow flexion and test the brachioradialis. Sorry. So for pronation and supination, obviously,
imagine holding a bowl of soup. You're in supination. That's how I remember it. That makes sense to me. Pronation, obviously, we have about 90 degrees each direction to kind of play with for this specific action. If we wanted to test that boundary a little bit further and overpronate, now we're playing with humeral internal rotation. Okay, same thing can go for supination. If I wanted to over supinate, obviously now I'm externally rotating my humerus, and as you can tell, I've got about a little bit more than 10 degrees of hyperextension in my elbow. And our primary elbow extensors being the triceps brachii with the 3 heads, and then the anconeus. Okay.
All right, cool. So you got to see me in my house, hopefully making more videos for you guys to easily go through and learn different muscle movements. We'll try to make that a norm in the next coming weeks. Secondary elbow flexor. So again, what we talked about, we have our primary movers, and then we have our synergistic muscles that aid in the movement that our primary movers do or perform. I did not articulate that sentence well. So our secondary elbow flexor would be the pronator teres, obviously coming from the medial portion of the humerus, like on the medial epicondyle down onto the radius. This muscle will actually kind of counteract the supination effect that the biceps brachii has. Being a prime mover, the biceps brachii will oftentimes supinate the forearm, but our pronator teres acts as a not a resistor, but it does help us prevent oversupination with elbow flexion. To touch on these ones, so remember for elbow flexors, remembering our nerve innervation specifically, the biceps brachii and the brachialis are both innervated by the musculocutaneous nerve. Again, going back to our brachial plexus, those peripheral nerves that we finally get to, those are innervated by the musculocutaneous nerve. The pronator teres, being a primary pronator muscle, obviously named pronator, that is innervated by the median nerve. And then our brachioradialis should help you guys because the name radius is in it, but it's innervated by the radial nerve. So biceps brachii, brachialis is innervated by the musculocutaneous nerve, and the brachioradialis is innervated by the radial nerve. Okay. Let's go into our primary elbow extensors. We have 3 heads to the tricep. Specifically, we have the long head, the lateral head, and the medial head. The long head being this guy right here. Medial head, you can barely see it in this picture, but it's right there. And then our lateral head obviously being more lateral. And then it has a common attachment onto the olecranon, okay? Our anconeus muscle is a very small muscle, and it's this guy right here, okay? It attaches onto the lateral portion of the humerus and onto the ulna, a posterior aspect of the ulna. Both of these muscles specifically are innervated by the radial nerve, so you don't really have to worry about too much. So anytime you think of elbow extension, radial nerve is your guy. All right. Primary elbow supinators, we have, again, holding a bowl of soup, like I mentioned in that video. We have our biceps brachii, and we have our supinator muscle. Very easy. Our supinator muscle does supination. Now, the supinator muscle is innervated by the radial nerve as well, okay? Biceps brachii is the musculocutaneous nerve. So here's our biceps brachii, and here is our supinator muscle that helps us turn our thumb up and allow our palm to be up. Secondary elbow extensors, extensor pollicis longus. So pollicis being the thumb. So that should help you kind of understand where it's going. Indices being a finger. So extensor indices. This is a anterior view. If you were looking at somebody's the top of their hand right here, this would help lift up your first finger. And then this would help lift up your thumb. So if you're going to do thumb extension, okay? It's a pretty meaty muscle right here. I don't really care if you guys know the nerve innervations for these two. If I ask you what other muscles perform, oh goodness, elbow extensors. Did I mess that up? I'm sorry. This should say supinators. I apologize. This should say, without confusing you guys, I'm so sorry. This should say supinators. Primary elbow pronators, you have 2, and they both have the name pronator in them, so you can't go wrong. Okay, so you have our pronator teres, which we mentioned before, which also is a secondary elbow flexor. We have the pronator quadratus, which is down here. Now this is the palmar aspect of your hand. So if you're standing in anatomical position again and you're touching the vein side of your wrist, it's right there. Okay, so if you wanted to turn your thumb down, you could feel that thing kick in if you're palpating on yourself. Pronator quadratus and the pronator teres are both innervated by the median nerve, okay? All right, secondary elbow pronators, we have two, flexor carpi radialis and then the palmaris longus. Palmaris longus being this guy over here, okay? And then we have our flexor carpi radialis right here. Again, I don't care about nerve innervations for these two specific muscles. I just want to know if there are other muscles that perform pronation at the elbow and the forearm, okay? So just, let me see. Okay, so just to review, again, we have primary elbow flexors, we have secondary elbow flexors, we have primary elbow extensors, there's just two of them, and then we have primary elbow pronators and supinators, and then we have secondary elbow pronators and supinators, okay? So when I close out this PowerPoint and I post it on Blackboard, I'll change that, I'll change this slide right here to say supinators. Apologize for that. Okay, so exam 2. What are we going to talk about? Well, we did some introduction into the leg and the knee for our first exam, but it wasn't the entire topic as far as coverage of content. So the exam will have knee lecture, knee readings, ligaments, let's see, muscles, innervations. I'll pass all this along to Bree as well. The ankle we'll go over on the exam. The shoulder for sure, we spent 2 weeks on it, so you should know it. Rotator cuff, muscle innervations, brachial plexus, bones, landmarks, open chain versus closed chain, degrees of freedom. Let's see what else. The elbow for this exam, the best thing is like the final is cumulative, so it's going to cover everything. But for the elbow on this exam, I want to know basic kinematics. I want to know specific muscles for, like, say, flexion and extension. I'll skip out on pronation and supination on this exam and save it because when we get into the wrist and the hand, we'll cover that some more. But let's go with flexion and extension, those muscles. Brachial plexus, obviously, because it did cover in the shoulder. Let's see. I can't think of anything else. No one sent me any questions, so if you have any other questions, obviously email me. Feel free to reach out. I'm home, so no big deal on that end. All right, you guys. I hope everyone does well. Take care. Enjoy your time. Let me see if I can figure out how to